Are we ready to get started? Yes?
Yes, let's get started.
Okay, good. Thanks, Chuck. Hello, everyone.
Hello.
My name is Katina Zaninovich, and I am the co-chair of the Healthy People, Healthy Communities campaign. And I am so pleased to welcome you this afternoon to our presentation. I'm very happy that you joined us. Just in recognition that beautiful guitar music extraordinaire that you were listening to before the program started was played by Tony Ybarra, and as well as being a musician that I'm sure many of you have seen all throughout our community, Tony is now a member of the board of directors of the Santa Barbara Neighborhood Clinics, one of our newest members, and we are so honored and proud to have him and grateful for his leadership as part of our board. So thank you, Tony, for that, because I've been on a lot of Zoom meetings, but I haven't had anything as lovely as that while I waited. I'm going to just start with a few housekeeping items, and that is we would like everybody to stay muted during the presentation. We're not going to have a discussion while the presentation is going on just because it's too hard, and we have a lot to get through and we want to get through all of it. So you will see a chat button or icon somewhere on your screen, and you can use that to type in any questions that you have, and then we will answer those at the end of the presentation. And hopefully a member of our team, because we have all these fabulous people behind the scenes, if they see you type in something because you're having difficulty with the presentation, hopefully they'll be able to answer it, because I'm afraid I won't. I also will make the disclosure so that all of you know that this is being recorded, but the good news for that is the recording will be available to you as well as the slide deck. So if during the presentation a slide is up and you couldn't see it or get all the information from it, it will be available to you. So you don't have to snap a pic of it or slow things down at all. So I think that's all the housekeeping fun items. So I am going to start with our first slide about Good Neighbors, our Good Neighbors program. Yay. So these wonderful women, Sybil Rosen and Sue Adams, Ger Giordano, and Jane Haberman have been part of the team at the neighborhood clinics during our campaign. And we came up with how are we going to fill what is essentially a $2.5 million gap every year that the clinic has to fill the gap for what is not covered by insurance, or even some programs which you can't even bill for, and yet which we think are vitally important for the health of our community. That's a big number, and Nancy Tilley and her crew do the most amazing job of securing government grants, foundation grants, research grants, but there is still well over $1 million or $1.5 million that has to be raised every year. So we were looking for something that is sustainable. And what better way to help a community than by being a good neighbor? And being a good neighbor means that you have decided that it's important enough for the health of our community that everyone in our community is healthy and has access to health, both physical and mental health, when they don't have the ability to pay for it. And that is what being a good neighbor is. You help us out every year with a monetary donation that goes toward that sustainability. And of course, we will invite you to exclusive events during the year. We will recognize you in the media and in all of our printed material, and you'll see that there's a little website at the bottom if you want to see some of our ads that are out there. Maybe if you can go to the next slide. Right now we have 36 good neighbors, and here's something pretty cool. In just the last day or so of when we were putting the slideshow together, we had 3 new people join our good neighbors. We had Mark Assman, who is our co-chair, my co-chair of our campaign, so that's sweet. Rob Pearson, I'm sure many of you know Rob and the outstanding work he did with the Housing Authority here in our community. And Bob Knight. Bob is a former chair of the board of directors of the neighborhood clinics and is on our campaign cabinet. So look at there, didn't even have a presentation, and we have 3 new people. So we're up to a total of 36, and we have an anonymous donor that will match $50,000 once we meet 50 members. So we're hoping you'll spread the word and or if you haven't, become a good neighbor yourself. Next slide. Look, there we are, all 31 of us. So we'd like to see that at a minimum of up to 50, so we get a matching grant. And then of course, the more it grows, the more we have a sustainable financial base to meet the needs of all the people that seek our help. So it's $1,000. I know you were waiting. How much is it? It's $1,000. And we'd like you to make that part of your annual giving, because if you can pledge $1,000 every year, then we can count on that to meet our needs. So I think, is there one more slide? Nope, look, that's the end of me. We're gonna go on to Dr. Fenzi and our COVID-19 update.
Katina, thank you very much. That was wonderful. And of course, we'll take more than $1,000 if you so desire. I would like to start our program today by thanking all of you for being part of this wonderful Good Neighbors healthcare innovations and spending part of your afternoon with us. And we're delighted that you're on board. I thought we'd start by just letting you know kind of where we are with our pandemic, because that's the top thing on all of our minds currently. Next slide, Talia. So this is what I put together over the weekend. So these were our numbers for the globe over the weekend. We were at, of new cases, 581,879 new cases. Today, according to Johns Hopkins, 495,684 new cases, climbing. Next slide. In the US, on the 6th, which was Friday, we had 132,797 new cases. Today, we're doing a little tiny bit better at 119,444 new cases. Not good. When it's above 100,000, that's just not good. Next slide. So for California, over the weekend, the new cases on that particular day, the 6th, was 6,713. Today, according to Johns Hopkins, it was 8,584 new cases. Next slide. And here's Santa Barbara County. We had 38 new cases on the 6th, and I have not had a chance to look at that number today for new cases in Santa Barbara County. But you can see from the graph that we've sort of leveled out at a level above where we were in June. And so we still have work to do. Next slide. This was from the 6th as well. This is where the cases were on that day. Mostly in, that arrow is in the wrong place, I'm sorry. It should be down, City of Santa Barbara with 7 cases and City of Santa Maria with 13 cases. That's kind of been what we've been seeing. Although the month of October, we had a huge number of new cases at Isla Vista with the students coming back to UCSB. Next slide. And this is our experience with our own patients. So we've been testing all along since the beginning of the pandemic, and we've had this sawtooth pattern here. But at the end of September and early October, you can see that for a while we went down to no new cases detected amongst our patients, and now at the last week of October, we were back up to 10% positivity rate. So the lesson here is that we all know the right way to bridge the gap until we have a vaccine, and I'm going to spend a lot of time talking about that in a minute, is that we do what we've shown works, and that is we wear our masks, we stay 6 feet apart, and we wash our hands a lot. So as one of my colleagues said to me, mask up, wash up, and stay away. Next slide. So let's talk about what's available to us now to help bridge this gap until these vaccines now are available to us to protect us. So as you have all heard early on, we had remdesivir as the antiviral. I'm not going to talk much about that. We've had dexamethasone, which we've been using for years for severe inflammatory disease. Diseases like asthma and all sorts of things. And that's been very, very helpful with the patients who are severely ill with COVID. The newest thing that's on the horizon now is monoclonal antibodies. So when I prepared this slide, Regeneron was the cocktail that our president took when he was sick, along with the dexamethasone and remdesivir. There's now a new a new monoclonal antibody product out by Lilly, and that's going to be very helpful as well. So the science behind it is very, very similar. So if you look at this model, this is a model of the spike protein. The spike protein is the light blue, and on that protein, that spike protein is designed by the virus to fit exactly in a receptor in our epithelial cells in our nasal passages. And that receptor is called the ACE receptor. So this is a stereoscopic connection. It's just like a key. So that spike protein fits exactly into the receptor. So if you can attach an antibody, in this case 2 antibodies, to that spike protein, then you can prevent it from fitting in to that receptor. It's like a whole new key. So this is a mock-up, this is a model of the 2 antibodies that exist in this monoclonal antibody cocktail, it's called. Next slide. So here's a little different way to look at it. The little red, the thing with the red dots on it is the virus. The blue thing is epithelial cell, and the little Y-shaped thing sticking off the edge is a representation of the receptors, and the little T's on the red T's on the virus are the spike proteins. And so the spike protein just fits exactly into that ACE receptor. Now, with the Regeneron, we've attached 2 antibodies to that, and it prevents it from being able to attach, and therefore you can't get sick from it. The reason that they like the cocktail idea with 2 different antibodies is it's very hard for the virus to make a mutation against 2 different things. And so that's wonderful. The Lilly antibody, monoclonal antibody, is just 1 antibody, but it's been shown to be very, very effective. Next slide. So I'm not going to spend a lot of time on this, but the reason for this slide is just to let you know how complicated it is to make these. You have to find somebody who's had the virus, and that's way up there in the left upper hand corner. And then you inject that person with, you collect cells from that person and inject it into a mouse. And the mouse will then make immune cells that carry that antibody. And so in the part number 2 there, you collect those immune cells and you separate out the antibody gene that you're looking for, in this case, the antibody against the spike protein. And then you go into mass production and you make a whole bunch of them. And then you put them in little vials, and then you test them, number 6, first in animals and then in humans in 3 phases. The first phase is very small number of humans that get injected, very courageous individuals. And the idea there is to see if it's safe. And then you go to phase 2, which is a larger number of individuals, to see if it does what we say it's going to do. Does it actually work? And then phase 3, we test the efficiency and we test the safety again with a much larger number of people. And then you go to the FDA and get approval for it. Next slide. So let me see if anybody has any questions apart, and then we'll go and talk a little bit about vaccines. No questions yet coming into our chat. So go next slide, Talia. So there are a lot of ways to make vaccines. And I'm going to show you 5 of them that are all part of the strategy for us to come up with a number of different vaccines. So the first 2, it looks like, are going to be out on the market are in the far left column with RNA and DNA. That you can also use live attenuated viruses, where we take the live virus and we cook it a little bit so that it doesn't work very well, so it doesn't make you very sick. And then we inject that into you and you make antibodies to it. Or we can actually, in the third column, we can kill the virus and just use the virus, the killed virus that can't reproduce, and have you produce antibodies to that. Or we can cut the virus up and take spike protein or whatever else protein and make antibodies to that by injecting it into the human. And then we can do this last thing, which we call a viral vector. And what they've done with this one, this is the AstraZeneca University of Oxford vaccine that's doing this. They have taken the monkey adenovirus, the monkey cold virus, and they have injected, I'll show you that in another slide. So let me just share with you some of the common vaccines that we're currently using in each of these columns. So the first column, we haven't done this before. The two vaccines that are coming out using this technology are the Moderna one and the brand new Pfizer. And it looks like Pfizer is going to be the first one out. It's about ready to go to FDA for approval, and then we will talk about what happens next. The live attenuated virus, we're right now giving to our children. Measles, mumps, and rubella is a live attenuated virus. Chickenpox is a live attenuated virus. And for those of you that are as old as I am, you remember that we had polio vaccine back in the 50s, which was a live virus, a live attenuated virus. That was the Salk vaccine. And we discovered that once we had wiped out polio, mostly, about 5 cases a year of new polio came out from the vaccine. So now we're giving inactivated polio vaccine to our kids. For the subunit vaccine, examples of that are the pertussis, whooping cough vaccine, hepatitis B, and human papillomavirus. The only other example of this viral vector was Ebola virus vaccine, which is now out and is being used. But this is going to be a much larger scale when we do this. Next slide, Talia, please. So just so you can see how complicated this whole process is, for the AstraZeneca vaccine, They take the chimpanzee cold virus and they modify it by cooking it or whatever so that it doesn't infect us. And they put that in the center of the screen. Then they take the SARS virus, the SARS-CoV-2 virus, which causes COVID-19, and they collect the spike protein and they collect the genes off of that spike protein and they mesh that with this monkey virus. And then that's what you inject into the human. It's actually not injected, like it doesn't have a needle like that. It's actually infusion that you do. But that will make antibodies against all of the proteins in that cell, which include the spike protein DNA, RNA. And I misspoke. This is an injection. I was thinking more of the monoclonal antibodies. Next slide. So most vaccines up until now the fastest vaccine we've ever made up until now was made in 5 years. Normally it takes 15 to 16 years to make it. And the reason for that is because we do it in stages. And financially, that's the only thing that makes any sense. So you do your initial research. If you look at this graph, it's in gold. And then you do your preclinical trials with animals. And then you do your phase 1 trial, which as you remember, is the trial that looks to see if the vaccine is safe. And before you go into the phase 2 trial, you complete the phase 1 trial. And before he goes into the phase 3 trial, you complete the phase 2 trial. And after you complete the phase 2 trial, then you start building your factories to produce the vaccine. And then you start to manufacture the vaccine. And then you ask the FDA for approval. So it takes a long time. Now we're going to go from the 15 years to 15 months with this vaccine. So we're hoping that from January of 2020, that we'll have a vaccine ready for distribution by August of 2021, a very short period of time. And so the way you do that, which is financially very, very risky, is you overlap a lot of these different stages. So as you can see, the preclinical is overlapping the phase 1 trials, which is overlapping the phase 2 trials, which is in turn overlapping the phase 3 trials. And at the very outset, you started building your factories and you started making the vaccine before you even had completed your phase 2 trials. Meaning that if that didn't work, you were out all the money that you just finished putting into that. And then you ask for approval. So that's how this process works. Next slide. Next slide, this was just sort of the same thing. Next slide, yeah, there you go. So here are the vaccines that right now, back up one, yeah, here are the vaccines that are now in phase 3, ready to come out. There's 8 of them. So if you look at the top of the slide, at the top of the photo, you can see phase 3, and there's a whole list of phase 3 vaccines that are almost ready. AstraZeneca, Oxford vaccine is there, Moderna is there, the Pfizer vaccine is there. I put a star next to Pfizer because it looks like that may be the first one out. I didn't count the Russia vaccine, which is the second from the bottom, because they skipped the phase 3 trials, as I understand it. And so some of our experts in this country, infectious disease experts, are a little bit concerned about the safety and the effectiveness of that vaccine. Next slide. So once you get all that done, you've got to distribute the vaccine. So the trouble with, well, I shouldn't say the trouble. The challenge with the Pfizer vaccine is that it has to be kept at a very cold temperature until you use it, because the vaccine itself will begin to deteriorate within about 3 hours after getting being out at room temperature. So this is on the on the left-hand side of your slide here. It shows you where on the thermometer you have to keep these vaccines. The Pfizer vaccine has to be kept down around the temperature of dry ice, which is 70 degrees, which is minus 70 degrees centigrade. So the way they do that, and this is a Pfizer shipping container, you've got a cardboard box on the bottom into which you have another cardboard box, which exactly fits the payload, so-called payload, which is 5 rows of 1,000 doses in each row into that inner box. And then you have this sleeve, this dry ice pod that goes around that whole thing, and you can ship this. And in fact, if you don't have, and most people don't have, a refrigerator that lets you get down to minus 70 to 80 degrees centigrade, you can replace the dry ice every 5 days, and you can keep this for up to 15 days. And once you're ready to use it, you take it out and you let it thaw for about 3 hours, and it's ready to give. Next slide. So when we decide who gets to be first, it makes sense to decide to really give it to the people who are most at risk. And there's 2 different groups when you look at this. You look at the populations that are most at risk. Pregnant women, this is the California plan. Pregnant women are very at risk because of their because pregnancy is an immune deficiency state. And the children that they're going to be caring for, who may be carrying that virus. And the occupational groups, obviously, are the critical healthcare workers and first responders, EMS, law enforcement, firefighters, et cetera. And then tier 2 is your high-risk populations, high-risk children, high-risk contacts of infants. Tier 3, healthier children. The high-risk adults they put in tier 4, I think that may end up getting moved up a bit to tier 2 or 3. So that's how we're going to distribute this. The first doses may be distributed as early as the first part of this new year. I've been part of a task force with the county working on the timing of all of this, and we're now getting trained to distribute these vaccines. We had a little a practice session with getting our flu vaccines out. So this is kind of where we're headed. Next slide. So let me stop here and see if there are any questions about the COVID and where we're going with this. The really good news about the Pfizer vaccine, which you all read, I'm sure, is that it's 90% effective. Meaning, what that means is that when they gave it to a group of, they gave placebo to a group of volunteers, and they gave the vaccine to a group of volunteers, the vaccine was 90% more effective in preventing the COVID-19 than placebo. Any questions? Well, let me just talk a little bit about our pediatric residency. Nancy and I have been working on this. The Cottage reached out to us, gosh, I think it's been about 18 months to 12 months ago, and said, would you be at all interested in helping us with a couple of residency programs? One of those was community psychiatry, and of course we are extremely interested in that. And the other one was pediatric residency. The board of Cottage decided to go with the pediatric residency program first because the number of pediatric providers in town was short, and the pediatricians in Santa Barbara are aging rapidly. I hate to say that. And so we're going to be out of pediatricians pretty quickly. And so if we can find a way to ramp this up, we want to be part of that. And Cottage certainly does as well. So what we're being asked to do is to provide the outpatient services with teaching supervision in our clinics. And Dr. Andrea Ruth, who, as most of you know, is a Harvard graduate and loves to teach. She did her residency at Boston Children's, one of the best in the country, and just loves to teach. So when we talked about this, gosh, she and I talked about this 3 or 4 years ago, And before I got the sentence out of my mouth, she said, yes, I'd like to be part of that. So we'll probably have another provider helping her with that. Nancy, why don't you talk about the conversations we've been having with the physicians at Cottage to get this thing rolling? Nancy, are you still on? Nancy, I don't see your microphone on. So let me start until she gets in. So we've had the two pediatricians from Cottage Hospital have been helping us out with this program. It's going to be a Cottage program, and we're just going to be part of it. The goal is to have 3 residents every year. Pediatric residency is 3 years long. And so when this starts in 2022, we'll have 3 residents coming through our clinics to do their outpatient clinic training with Dr. Ruth. The second year, they will have those 3 plus 3 more. And the third year, we'll have 12. We'll have 9, I'm sorry, I said 12. So that's pretty exciting. The Goleta Clinic is structured in such a way that we have a sort of pediatric wing, and we'll be using that for the training program. There's plenty of room for the residents to have their own computers and desks at the same place, and providers, the attending providers, can interact with them there. Nancy, was there anything else you wanted to add to that? Nancy, you're
Thanks,
muted.
Dr. Fenzi. Sorry, I couldn't get off of mute. Good afternoon, everyone. This is an exciting time to actually be asked by Cottage. We know we have a shortage of medical providers, as Dr. Fenzi said. We are at Santa Barbara, even at Santa Barbara Neighborhood Clinics, we have a shortage, and it's very difficult to recruit medical providers to come here because of the cost of housing. And so being able to work with Cottage, particularly because they have these outpatient clinics and we can take care of our own patients right here without sending them somewhere else, this is really important. So in order to be able to take care of the whole patient through our patient-centered medical home, this is really a wonderful opportunity, and we're looking forward to partnering with Cottage on this whole program. Thank you.
So next slide. So Nancy, why don't you start off with the asthma mitigation project, because this is taking the treatment of asthma to an entirely new level, which is very exciting to us. Nancy and Kalia, our grant writer, who's also controlling the slides right now, were able to get this fantastic grant, $500,000, that will allow us to do another phase of asthma treatment. Nancy, why don't you talk about that?
Thanks, Dr. Fenzi. As you know, asthma is prevalent everywhere, and in Santa Barbara County, 18.8% of the children here have been diagnosed with asthma. We at the Santa Barbara Neighborhood Clinics have over 500 patients who've been diagnosed with asthma. And this is an opportunity for us to be able to provide education to children, adults, and their families. But even more importantly, it also provides us an opportunity to do home visits and to actually make some changes in the patient's home. We have funds available within the program itself to serve over 150 patients in making minor alterations in their home, things as checking on bedding, giving them a HEPA filter to clean the air, and some other pest mitigation inspections. And so this is really going to be a program that's going to make a big difference in the lives of those who have been diagnosed with asthma. I was just speaking with Dr. Ruth, and the nurse, Jaylon Oskan, who's going to lead this program not 2 hours ago. And they're very excited about bringing on an asthma educator, the training that's available to our staff to educate not only in asthma, but other health-related items, and then to be able to be certified. So we have a certified asthma educator on staff here is really going to be fabulous. And so this particular grant is focused on the uninsured and underinsured. So those people who would not otherwise have access to care will be able to have this treatment. And then it also is specifically focusing on culturally and linguistically appropriate visiting services. So we have hired an asthma coordinator for the program who is bilingual, bicultural, who will be working with families and communities of color who really have disproportionate rates of asthma. You have other things you want to talk about with this?
I was just going to say, I might add to that, having made home visits most of my career, it's amazing what you learn about your patient when you visit their homes, the challenges that they might have in getting up the stairs, or the asthma is another one. Asthma is still a killer. And so if you can find and mitigate the triggers, this is going to be a game changer in my mind. Next slide, Tilia. Nancy, why don't you?
I'll talk about another item that actually a trigger for asthma is ACEs, or Adverse Childhood Experiences. And we're moving our program from the pediatric stage to older children and adults to be able to screen for adverse childhood experiences. We at the Santa Barbara Neighborhood Clinics have had a program called the Santa Barbara Resiliency Project. We started screening in 2017. Dr. Fenzi worked with myself and another pediatrician about five years ago. Her name was Monica Gross. Some of you may have been familiar with her. She had this in her practice in Alaska and was really on the forefront of making sure that we became aware. And through the generosity of the James S. Bauer Foundation and John Clark, who helped convene community stakeholders, the Santa Barbara Resiliency Project went from a planning to pilot to study phase. And I thought I'd talk a little bit about our accomplishments there before I dive into screening and toxic stress in adults. Could you go to the next slide, please? So what are adverse childhood experiences and why are they so important? Well, there's three different areas that essentially have proven to have adverse childhood experiences which impact and affect not only children, but it's very important to address this early in life to help build resiliency, through protective factors and other support systems. Also, adults who have experienced adverse childhood experiences have other diseases like cancer, asthma, heart disease, and all this could be triggered or is related to decisions that are made based on things that happened to people in the past. So instead of asking people, what is wrong with you? We now ask them, what happened to you? And so in the area of abuse, there's physical, emotional, and sexual abuse. In the area of neglect, there's physical neglect, not feeding a child, not eating properly, being malnourished. There's emotional neglect, people who don't have love or don't have a person in their life that makes them feel important. And then there's household dysfunction, mental illness, someone that is in the household with mental illness, a relative who's been separated because of incarceration, a mother that's been treated violently through domestic violence, a person in the household who has a substance use disorder. That's how we refer to substance abuse now. And then a loss of a parent through divorce. You can go to the next slide, Talia. The Santa Barbara Resiliency Project is a study, we have a randomized control study where we screen infants 0 to 3 and their parents with the ACEs questionnaire. And that questionnaire addresses some of those adverse childhood experiences that we just saw on the previous page. And it couples that experience with interventions. Our partners on this project are CALM, Child Abuse Listening Mediation, and the University of California at Santa Barbara. And the interventions that we provide for some of the participants are a wellness navigator who helps the family build supports and with the social determinants of health addressing. And then some of the families in the trial have a wellness navigator and then a clinic intervention. That intervention occurs at the clinic during the well child visit. And so they're not having to make a separate trip in order to be able to receive that intervention. And that's provided by a CALM therapist. And lastly, there are those who get a wellness navigator, a clinic intervention, and then a home intervention, a home visit, in which they look at how the parent attunement is to the child, what the environment is. They also address parent satisfaction and whether a child is thriving. And the reason this is so important to happen in the pediatric setting is because a pediatrician is a trusted adult, and it may be the only adult that that child gets to see outside of their caretakers. You can go to the next slide, please. So what we have accomplished in our Santa Barbara Resiliency Project, and we are not completed with our study. Our goal is to have 100 infants and their parents finish the program. We have at this point screened 357, out of which 115 are actually enrolled in the interventions. We have to continue the study because we do have people who drop out, because particularly now with COVID, we've had to halt the study for a little while until we were able to get back to doing some visits virtually. And so we'll continue to do that. We're hoping to be completed with the study in the next few years. But really, some of the exciting work that's already happened is we've posted published three white papers. I can't read what they are, but I will tell you, and they're available, we can send them to you. One is trauma responsive care in a pediatric setting, feasibility and acceptability of screening for adverse childhood experience. And that's been published in the American Journal of Community Psychology. Promoting equity and resilience, Wellness Navigators' role in addressing adverse childhood experience was published in the Journal of Pediatric Psychology. And the implications of ACEs screening on behavioral health services, a scoping review and systems modeling analysis was published in American Psychologist. And these papers were written with our staff. In fact, on the wellness paper, our wellness navigator is listed as one of the authors, but they were led by Drs. Maya Barnett and Miriam Kia Keating of UCSB at the Department of Counseling, Clinical, and School Psychology. So we're very proud of what we've already accomplished in our program, and the Santa Barbara Neighborhood Clinics is part of really a leader in this work. We've been nationally recognized, and we are also working currently with the state of California on a grant that was funded for a learning collaborative called the CalQuick, or California Quality Improvement Collaborative. Can you go to the next slide? So in addressing adverse childhood experiences for everyone, we wanted to work with the state on addressing or on reducing toxic stress by 50% in one generation. And the ways that that's going to happen are listed below. And what's really important to understand, again, is we're preventing disease by addressing toxic stress. We all have stress, and that's a good thing, because if a bear is running at us, we have to know that we better get out of there quickly. On the other hand, if you're experiencing toxic stress on a regular basis, your system is in that ready state, and that is what causes the breakdown of your systems physically and psychologically to be able to have an appropriate response, and it just wears you down. So these are the areas that are being addressed and ways to really combat the statewide ACEs and what tools, how we're going to do that. Next slide. So this is a screening workflow for pediatrics, and it's very much the same for adults. The clinical staff goes through a questionnaire. It's called PEARLS, and then based on the responses to the questionnaire could either be identified where the individual answers each of the questions, or it could be de-identified where you just say how many of these you've had. And just to give you an idea, all of us have ACEs. And I'll show you the screening in a bit, but I personally have 7. And so a lot of people vary, and it doesn't really have a lot to do with your economic upbringing, but it does, but those people who are of low income or modest means really don't have the ability to address this because they aren't getting as much of the medical care and psychological care that maybe they need. They're not even maybe getting nutrition or having a place to sleep, which is a really important part of dealing with adverse childhood experiences. Julia, the next slide. So here is the algorithm that the state uses and what we will be implementing. If you are of low risk, meaning you've answered between 0 and 3 questions positively, or your score is 0 to 3, you don't have any other health conditions, you'll be provided information about what ACEs are, what toxic stress is, and how you might be able to acquire some protective factors for that. Just because you're at low risk doesn't mean you wouldn't have any need to have other services or interventions. But the algorithm here says if you're of low risk and you have no health conditions, then you'll be provided at minimum education. And then if you are at 1 to 3, which is an intermediate risk with associated health conditions, diabetes, heart disease, hypertension, you will not only be provided education, but you are also going to be provided a treatment plan. And that will be jointly prepared between you and your provider. And for those adults with a score of 4 or more, whether they have associated health conditions or not, they will again receive the education and a treatment plan for being able to build resiliency. And they'll be linked to support services and other treatments. Could be behavioral health treatment, it might be substance use disorder treatment if that's discovered, and so on. You can go to the next slide. So this is a copy of what the Adverse Childhood Experience Questionnaire looks like. And again, if you look down it, you could answer it for yourself. It refers back to the first slide I showed you about what ACEs are, having a separation of parents, not having enough food, or being able to have both of your parents live with you, domestic violence, unwanted sexual contact. They are all listed here in this questionnaire. And again, this is a copy of a questionnaire that is de-identified. You don't tell which of the questions you answered yes to. You just put the total score at the bottom of the page. And then this is discussed with the provider, between the patient and the provider, and they make a plan of how to move forward. And that plan is in a toolkit that's actually published by the state of California. You can pick that up and look at it. It discusses things like the 6 pillars of treatment. Can you go to the next slide, Julia? And so here are the 6 pillars of treatment. And they're really not anything that's more than how you really should be making decisions about taking care of yourself, having good sleep, eating properly, exercise, being mindful, having behavioral health supports, getting referrals for behavioral health, and again, having those supportive relationships. So for an adult, it would be a parent or a friend. For a child, it would be a mentor or someone who they would be able to feel supported by. That's a big part of adverse childhood experiences. And so our organization is moving forward. The state is recommending that all children be screened for adverse childhood experiences annually until they reach the age of 18. And then afterwards, each adult be screened at least once in their lifetime to determine if they have adverse childhood experiences that are impacting their health. You can go to the next slide. So I'll just start off on the Healthy People, Healthy Communities campaign. We started a campaign in 2017, and many of you on this program have been an integral part of the success of our campaign. What you see in front of you is a picture or a rendition of what a new Westside Clinic would look like on Mitchell-Turena Street. We're very excited to be moving forward, and I have to thank many of you who served on our campaign cabinet and our leaders of that, Mark Asman and Katina Dzaninovich, because without their leadership and many others, we wouldn't be where we are. You can go to the next slide. Maria, do you want to take over?
Yeah, I did. So as you know, since 2017, we embarked on this campaign, and it was a true collaborative of 56 individuals that met frequently and dedicated themselves. And now we're proud to announce that we're at 98% and only just 484, now 481 with the 3 good neighbors as of today. So we really applaud the vision and your dedication, and it's been a joy for all of us to work together to striving to get to have this beautiful building and to take care of the health of Santa Barbara. And next slide, please. So here is a snapshot of everybody who was involved. And again, Katina still hanging in there with us, leading the Good Neighbors along with Sybil and Gerd and Mark Asman, who joined the Good Neighbors today, and all of the folks, many of you who are on this call. We couldn't thank you enough. And we're looking forward to a long, prosperous relationship and, of course, a beautiful new state-of-the-art clinic on the west side. And with that, we have one last thing to share with you. Talia, next slide. Pencil in, I'm going to say pencil, save the date of Tuesday, March the 2nd, where we will be honoring our California Surgeon General, Nadine Burke Harris, who was brought ACEs to the forefront, who you just heard in depth about ACEs, and also our Santa Barbara County COVID Task Force, who certainly deserve this honor of keeping Santa Barbara healthy. And it's been our honor to work with you. We hope that we'll have many more of these innovations in healthcare. And we want to open up the floor next for any questions that anybody might have about what we're doing, what we need to go forward, or how you can become a good neighbor or join the campaign. Thanks.
Talia, why don't we stop sharing so we can see each other? Yeah, there we go.
Yeah.
So any questions and any comments would be welcome, or would actually be wonderful.
Dr. Fenzi, I'm put my question in the chat, but I'm going to ask it. It's on COVID from in the very beginning. So I've read
Yes.
a couple articles in the New York Times, and this is what happens too when you spend too much time and you're on your computer too much. Also, this interview that Dr. Fenzi had with a show that's called something like This Week in Virology or what, but it's about testing and something that they call the cycle threshold, and
Yes.
whether our tests have too high of a cycle threshold, because maybe somebody who tests positive is not necessarily infectious or needs to be quarantined, and more cases scare us, but does a positive test mean a case? So I don't know. I don't know enough about cycle thresholds. I know Dr. Fauci said that it's hard because these could just be like dead nucleotides or something out there, and they're not necessarily infectious. So I wondered if you could enlighten.
Yeah, Katina, that's a fantastic question. And it shows your RN background.
Well, maybe, but that's all I know how to do is ask the question.
Let me take a stab at it.
Okay.
So the way PCR works is that it's an amplification process. So you take a virus and you multiply it, you amplify it until you can't amplify it anymore. And so those are the it's called CT cycle. The number of cycles it takes until you can't find it anymore. So we think that after 15 cycles, that's about where you'll see viruses that are replicable, meaning viruses that can still cause infection. Okay. Beyond that point, you may still be able to detect some more viral particles, but it's thought that they're not infectious. They may be, as you mentioned, Katina, they may be pieces of virus that you still pick up and still cause the PCR test to be positive. So this is one of the reasons that Dr. Fauci and others are suggesting maybe we do the antigen test instead. And antigen is just pieces of the virus, and the tests are not as sensitive as the PCR test. The PCR test is, if it's positive, it's probably, you have little particles in you from that virus, but they're not necessarily infectious. So if you do an antigen test every single day, that costs $4 to do, and then all of a sudden one day you come out positive with a positive antigen, then you quarantine. You don't have to do any, you don't have to have a lot of infrastructure to do that. And so that keeps people who test positive out of circulation for the 14 days until they cleared the virus. We think that that's the average, we think the virus is cleared in 8 to 10 days. So 14 days sort of gets you out beyond that so that you're not infectious past that. Now, that's not true for people who've been bad sick and been in the hospital. They may still be infectious beyond that 14 days. Right. But for most of the folks that don't get sick enough to have hospitalization because of their lack of being able to oxygenate or their cytokine storm, they're cleared up within 8 to 10 days, outside 14 days. And that's where that comes from. So if you do that every single day, then you're going to take a lot of people out of circulation who test positive. Right now, we don't have enough tests to test everybody every day. So right now, we wait until you have symptoms that are consistent with COVID to do the testing. Well, the symptoms of COVID are the same symptoms of adenovirus and the flu virus and a whole bunch of other things, except for the loss of the sense of smell and taste, probably. And so some outfits are now using that as one of their screens. Asking if I'm about ready to lose my little thing here. I'm sorry, my battery's low.
Okay.
Does that answer your question? Cycle.
Yes.
So CT says cycle time, it's the same thing.
Got it. Thank you.
That's a great question.
Oh, good. Yes, Mark?
Mark.
Not to get into too much detail, but the rendering was lovely for the new Westside Clinic. But could you give us just a small sampling of like how many medical exam rooms we have in the current West Side Clinic, what we would have in the new, and the new addition to the West Side Clinic obviously would be the dental as well as expanded behavioral. Could somebody sort of just
Nancy?
briefly?
So let's talk to our project manager. Oh, good, she's on the line. Nancy, would you take that question?
Thank you. Our current, and thank you, Mark, for that question. Our current facility has 6 examination rooms and a very small lab. It also has a behavioral health room, but you have to walk up these very narrow stairs, and it's a little room off to the side. You can't, if the patient comes in and the counselor's there, when they sit in the room together, one of them won't be able to stand up because they'll hit their head on the.
Yeah.
And so it's really important that we have enough space to serve our patients. And this building that's planned across the street from the current clinic will have 9 medical examination rooms. And around that, there will be interdispersed between the medical examination rooms will be behavioral health counseling rooms, so that we'll have a fully integrated medical and behavioral health. Another exciting project, we won't say too much because then we can have another session, but it's working on our integration of behavioral health and our physical health or our primary care. And this is another exciting thing. And having a building that's already established is going to be a way that this can be successful. We're also adding 6 dental operatories. And right now there are about 1,500 patients who come from the West Side to have their oral health needs met at the East Side Clinic, which is impacting the East Side Clinic, not permitting them to see all the patients that they could see on the East Side. And so when we open that facility, there will also be a dental operatories as well. But in addition to that, we have a large meeting and community room that we hope will be able to be utilized throughout the year by not only Santa Barbara Neighborhood Clinics, but members of the community as well. And so we were definite and intentional about planning a clinic that could well serve the community. And we took into consideration some of the things that we were faced with in COVID, making the walkways larger so you could have someone walking up and down the stairs at the same time and be about that 6 feet apart, making the hallways larger and making sure that our staff had enough room to socially distance while they were working, and being able to have our dental operatories closed. In the beginning, they were all open, and now we've had to build separate examination rooms for the dental operatories as well. We're very excited, and we have our community benefit designation by the city. We've been through the preliminary review team, and we are working on submitting our application to the Architectural Board of Review, and our fingers are crossed that we will get in for a review on December 14th, which is the next time the Architectural Board of Review will be meeting, that we would be eligible to apply for. So exciting things.
Thank you for the question, Mark.
Do we?
Any other
Well, it looks like Sybil has a question.
Sybil.
Maybe it's an answer. No, I really just wanted to say how proud I am to be a part of this amazing group of people, staff and supporters and I'm grateful because being a good neighbor for me right now is $1,000 a year commitment to the clinics, and hoping that I can do more in the next year. But that I'm informed, and when people go out and when I speak to people in the community, I feel so knowledgeable when they say, what's this problem? And we've got all of these problems in our community, and I can say, aha, we have the clinics and they're doing something about it. And it's very inspirational. So I think that it's, I'm grateful to be a part of it. And I'm always telling people that if we don't take care of the people in our community that cannot really afford the top-notch medical care that we get for a gazillion dollars, that we're all going to get sick.
We're at risk. Yeah.
We're all at risk, absolutely. So thank you so much. I probably got a little more information than we needed to hold in our brains today, and I'm impressed that you're able to do that. But thank you so much for opening our eyes.
Thank you, Sybil.
Sybil, thank you very much for your comments. They were very, very kind. I appreciate that. And we really, really appreciate the support from everybody that's on this call.
Yeah.
I can't see everybody on here. Can you see who else has a question?
I do have a gallery view. I don't see anybody waving their hand or anything. And there's nothing in the chat room. It's pretty amazing.
Well, thank you very much.
Me, I'm looking at
If
a
you
chat.
have for us,
And again, if anybody would like more information on seeing the becoming a good neighbor, certainly contact me at the clinics. I'm happy to do so. And I really appreciate this group of women who helped put this together. You energize me every day.
Mhm.
Thank you.
Thank you. Thanks everybody for coming.
Thank you.
thank you. It's
Thanks to
you.
all.
been one.
Thanks.
Thanks for being here.
Yeah,
Thank
more
you.
to come. More to come.
Happy Thanksgiving, everybody.
Bye-bye.
Yeah,
Yes.
Bye.
Well, same to
care.
you.
bye.
Bye.